Board exams are engineered to overwhelm. They present a wall of data, overlapping symptoms, complex lab values, layered scans, to exceed your working memory. Attempting to brute force memorize thousands of individual disease presentations is a common mistake. It is exactly what the test makers expect, and it is a path to failure. Expert diagnosis relies on systematic, algorithmic elimination. The process identifies and removes the noise until only the correct diagnosis remains. To execute this, you must treat the vignette as a set of clinical constraints, hard rules that cannot be broken. Any complex imaging vignette can be solved using a three-part filtration system: morphology, demographics, and signal correlation. The first filter, morphology, identifies the physical structure or the binary state of the anomaly. The second and third filters lock in the patient's age and anatomical context, then measure the tissue physics generated by the scan. Applying these three filters in sequence neutralizes traps by stripping away distractor options. The algorithm begins by forcing a strict binary morphological split. You must establish this baseline before reviewing secondary data. This model of a pediatric neck mass starts by splitting the diagnosis into two physical states: cystic or solid. For a cystic mass, the next branch is anatomical. We filter the remaining possibilities by location: midline or lateral. A midline mass sitting posterior to the tongue and anterior to the hyoid bone identifies as a thyroglossal duct cyst. A lateral track, anterior to the sternocleidomastoid muscle, shifts the diagnosis to a branchial cleft cyst or a necrotic lymph node. This binary logic applies to physiological states in the neonatal chest as well. On an X-ray of a congenital heart, the mandatory first step is determining the oxygenation status: cyanotic or non-cyanotic. Tetralogy of phalanx, TAP VR, transposition, truncus, and tricuspid atresia sit exclusively on the cyanotic side of this split. If the vignette specifies a cyanotic newborn, you can immediately eliminate ASD, VSD, PDA, and coarctation from consideration. Establishing a morphological or physiological binary split acts as a rigid firewall, preventing you from entertaining any impossible answers. Once morphology is set, the demographic anchor filters the remaining possibilities based on age and gender. Pediatric liver masses illustrate how time rewrites a differential diagnosis, creating two isolated buckets based on age. Between ages 0 and 3, the viable differential is restricted to hemangioma, hepatoblastoma, or mesenchymal hamartoma. Reaching the age of 5 invalidates the initial list. The viable options shift to hepatocellular carcinoma, fibrolamellar HCC, or embryonal sarcoma. Diagnosing a 6-year-old with a hepatoblastoma is a failure of the demographic filter. Gender and specific life stages provide the same restrictive force. Adult pancreatic cysts follow these demographic anchors precisely. Serous cysts are typically found in elderly females, while solid pseudopapillary tumors are anchored to young females. When a vignette clearly specifies a patient's exact age and sex, it is providing the most critical filtering mechanism in the text. Demographics provide absolute constraints. If the patient's profile does not align with the pathology's window, the diagnosis is incorrect regardless of the imaging. The final filter correlates the remaining options with precise imaging signals and pathognomic evidence. MRI interpretation follows a deterministic physics matrix, where tissue composition dictates the exact signal output. T1 brightness follows specific physical rules. If a lesion is T1 bright, it contains fat, melanin, subacute blood, or protein-rich fluid. T2 brightness correlates directly with water, edema, or high fluid content of most standard tumors. Diffusion restriction identifies dense matter, such as the hypercellularity of an aggressive tumor or the thick nature of pus in an abscess. Combining these physical rules allow for the deconstruction of complex puzzles. In a layering lesion, multiple substances coexist in one space. Fat within a layer is identified because it registers as both T1 bright and T2 bright simultaneously. Pus in that same lesion reveals itself as T2 dark, combined with clear diffusion restriction. These rigid signal physics allow the diagnostician to clearly reverse engineer a mass's exact physical composition based entirely on its observed tissue properties. Board exams use comparative pathognomics to test the differences between visually similar diseases. This table compares two pediatric renal masses, neuroblastoma and Wilms. Both present as large abdominal masses in children, so morphology and demographics cannot separate them. The separator is the delta. Neuroblastoma commonly calcifies and encases vessels, whereas Wilms rarely calcifies and actively invades vasculature. This logic applies to the comparison between hepatocellular carcinoma and fibrolamellar HCC. The visual presentation of these liver masses can overlap significantly. The primary separators are the presence of cirrhosis and the patient's age. Standard HCC occurs in older patients with cirrhosis. Fibrolamellar HCC occurs in young patients with healthy livers. Mastery requires isolating the single variable that breaks the symmetry between identical-looking diseases. Take control of the data. Dictate the precise morphology. Anchor the specific demographic constraint. Correlate the underlying imaging physics. Shift away from reading vignettes as passive narratives. Actively scan the text for binary splits and absolute demographic constraints. High-stakes questions are constructed so that every detail either feeds the algorithm or identifies a distractor. Trust the decision tree and the physical rules of the scan. The correct diagnosis is the only option left standing.